Thank you, Karen. Thank you, Tracy. Thank you to all of our organizers today. So today, I'm very excited to talk about the best practices in screening, referral, and diagnosis in fetal alcohol spectrum disorders. As Tracy has mentioned, I have a big interest, both clinically, research, scholarly, and in terms of teaching for prenatal drug and alcohol exposure. I first started doing these diagnostic evaluations at the University of Minnesota Medical School at the FASD and International Adoption Clinic. And there, I firsthand saw the importance of the multidisciplinary work, as well as how comprehensive, but at the same time, how difficult this evaluation is. And after that work, I continued to do diagnostic evaluations at where I am currently at the School of Professional Psychology at Wright State University with my doctoral level trainees. And diagnostic evaluations, differential diagnosis, and any type of assessment is my area of expertise and an area that I truly enjoy working with. So today, as part of our second presentation and training, I'm happy and very excited to share some of my experiences and knowledge that I've gathered in this area all with you today. We will take questions as we go, so I will pause at certain spots and Karen will be reading the questions, so please feel free to put your questions and then I'll try to address them as we go along so that we don't have these ton of questions all at the end. And then at the end, I will also linger and stay a little bit for those who are interested to share any information or to ask some further questions. So without further ado, I'd like to go ahead and get started today. So as you have read before joining in today, our objectives is to identify the best practices for how to screen for FASD, and then learning about what will be some good practices for the referral process, and also to learn about different diagnostic methods that are out there to provide a diagnosis for FASD. So in my first training, which we did last month, and hopefully I have some of you who were able to participate in that one as well, where I shared a lot of more detailed information as to what is FASD, what are some of the red flags, what are some of the symptoms, and the clinical presentation over the lifespan. So therefore, I will really not go into those specifics, but I just put one slide for those of you who might have missed that training, and just to give you a general understanding as to what FASD is. So fetal alcohol spectrum disorders, as we call FASD, is an umbrella term. It is not a diagnostic term. Today we'll talk about the different diagnoses that are under the FASD umbrella term. But it's a term that we use to describe the set of disorders that arise as a result of a child being exposed to alcohol in utero, which we call prenatal alcohol exposure. We usually use the word PAE to denote that. So today we will be talking about different diagnoses that fall under this FASD umbrella. Overall, FASD is the most common leading cause of preventable cognitive impairment, developmental disabilities, and birth defects in the United States as well as in the world. The prevalence is around 2 to 5%. And when we say preventable, a lot of the cognitive impairments that arise for any children is usually due to chromosomal abnormalities, genetic abnormalities, as well as some unknown etiology. However, for FASD, we have a known etiology, which is a mother's consuming alcohol during pregnancy. If there is no alcohol consumption during pregnancy, then we do not see FASD. Therefore, what we know from the literature is that alcohol is a teratogen, which means that it can pass through the placenta when the baby is in utero, and therefore will have long-lasting impact in terms of some changes in the structure of the brain, in different brain structures, and therefore, as a result, changing some of the functions in the brain, which we will also talk a little about today. So as I said, it impacts 2 to 5% overall. Therefore, unbeknownst to many people, it's actually very prevalent. It's out there. It's just that we are not paying enough attention to FASD as much as we pay attention to other neurodevelopmental disorders such as autism, ADHD, and learning disabilities. So therefore, another goal of ours through these series of trainings that we are providing is to spread awareness, is to increase knowledge, is to increase some information regarding different aspects of FASD, of which today I'd like to focus on the diagnostic part and then the screen and referral part. So hopefully this is like a little bit of a summary for those who did not have a chance to attend our first presentation about the ins and outs of what FASD is. So this slide and this visual gets frequently used in a lot of the FASD presentations, and I think both of these have really good significance, and that's why I also wanted to show you. The first one on the left, which is the umbrella, indicates that fetal alcohol spectrum disorders, just like the autism spectrum disorders, is on a spectrum, meaning that not every individual, every child that gets exposed to alcohol in utero gets impacted the same way. They all get impacted in different ways and in different severity and in different types of presentation. Therefore, unlike, for example, ADHD, where we would say a child has ADHD, we can say it's mild, moderate, or severe. But then for FASD, we have quite different presentations. And therefore, FASD has been denoted as an umbrella term to describe all of the disorders that fall underneath that, which each of these we will talk about specifically. So therefore, we should really understand that it's not a clinical diagnosis, but the ones underneath are clinical diagnosis. And FASD is a term that puts all of those disorders together under that big umbrella. And then if you look at the picture on the right, I think that is a very meaningful one, where on the top of the iceberg, what we can see is the FAS. FAS is what we call fetal alcohol syndrome. Fetal alcohol syndrome is, or the partial, fetal alcohol syndrome. This is where we see the actual physical impairments. And when I say physical impairments, those are the things that we can see and detect in the individual, such as the facial dysmorphology, such as the facial features that we will later talk about. So once those are detected, measured, and evidenced by genetics or by developmental pediatricians who are qualified to measure those facial features, then we can say that the individual has fetal alcohol syndrome, which is the more severe form of FASD. However, we also know that not all the individuals that fall under the FASD umbrella will show all of the facial features. Only children who were exposed to alcohol in the first trimester and then consistently throughout all the trimesters then will display the facial features. However, we know that that's not the case for a lot of children whose mothers drink during the different trimesters, such as the second trimester, the third trimester, when they are probably maybe experiencing more other different types of issues. The timing happens to be that time. So then we could say, then what happens to all of the other children who do not show the facial features? So as you can imagine, the children who show the facial features will be picked up, will be referred to specialty clinics, to genetics, to developmental pediatrics, to doctors. And then the parents, both either the biological or the adoptive or foster parents or the teachers, will want to get some answers regarding what might be going on in that child, because they can visibly see they might be different. So that brings us to the question, well, what happens to, this is only around that 20%, what happens to that other 70–80% of children who do not show any of the growth impairments, who do not have microcephaly, like who do not have a smaller head circumference, who do not have the facial features? Well, as you can see in the down part of the iceberg, that is kind of like represents the rest of the children who do not have the facial features. However, they do have what we call the functional deficits of FASD. And all of these functional deficits are things such as difficulties with memory, problems with cognition, difficulties with adaptive skills, some motor skills, behavioral dysregulation, and so forth. So why this is really important to know is that once we see a child with Down syndrome, okay, and we see the facial features and everything, it's there, it's there. We do not need to look for anything else. And then we can reliably say that this child has Down syndrome. But I just wanted to emphasize that is not the case for FASD. Only the children who have been more severely impacted, whose mothers drank all throughout pregnancy, including the first trimester, will only show the facial features, and that's going to be only at the top of that iceberg that we will be able to see. And then the reason why I'm really emphasizing this is because when we are doing our diagnostic work, okay, the most of the children that we will be evaluating will be the ones that are under that iceberg, that will be who will not necessarily have the FAS, but who will have all the functional deficits, the impairments, who will fall under the cracks, under the radar, because they are not showing the facial features or the growth impairments. Okay, so that's why I think this is a really important piece of information that we all need to know. So what are fetal alcohol spectrum disorders? As I said, it's an umbrella term, and it describes these several different diagnoses that go underneath that. There are basically 4 diagnoses under FASD that are based on different symptom presentations and that are based on different levels of alcohol exposure. We will again talk about each of these separately, but I wanted to kind of put that out there as in a chart where you can kind of, like in this table, as you can see, it says the diagnosis, the name of the diagnosis, then the next one is growth. When we say growth, it's what it means is that growth impairments such as height and weight, most of the time being under the 10th percentile, as well as the head circumference also being under the 10th percentile, which can sometimes lead to what we call microcephaly. Then we're looking at facial anomalies. Okay, so these facial characteristics are having smaller eye openings, having a smooth philtrum, and then the philtrum is the part where the end of the nose, the one that's starting from the top of the lip and then going down on the edge of the lip. Okay, so that area is usually, if you do that movement, it usually has a little bump up there. So for children who show the FASD, the FAS facial characteristics will have a smooth philtrum. And then the third one that we look for is a very thin upper lip. And there are specific measurements that go with how thin, that upper lip is supposed to be. But when those 3 are put together, those are what we call facial dysmorphology or facial anomalies, characteristics of fetal alcohol syndrome. Okay. And then the third one is central nervous system abnormalities. When we say central nervous system abnormalities, what we are really looking for is the impact of alcohol on the structure and the function of the brain, meaning that alcohol impacts several different areas in the brain. That leads to difficulties with cognition and IQ, problems with memory and learning, problems with executive functioning skills such as planning, organization, good judgment, initiation skills, problem-solving skills, difficulties with fine or gross motor skills, problems integration, problems around sensory integration, a lot of difficulties with behavioral emotional dysregulation, and problems in adaptive behaviors. So all of these are as a result of the damage and impact of alcohol prenatally in the brain. So we denote and give it a name as to central nervous system abnormalities or impairments. And I'll talk a little bit more specific about each of these. And then the last criteria is whether there was, of course, prenatal alcohol exposure or not. And of course, as I said, if there is no exposure, we do not have FASD. So as you can see, prenatal alcohol exposure, the one on the right, it says yes for all because it has to be there for all conditions and for all diagnoses. Central nervous system abnormalities are there as well in a severe form. And then for the facial anomalies, only fetal alcohol syndrome has the full facial anomalies. Partial FAS has some of it, but not all of them. And then growth, the growth that I mentioned, height and weight and head circumference, is only impacted and deficient in the full-blown version, which is the fetal alcohol syndrome. But as you can see, it's not impacted in partial, it's not impacted in alcohol-related neurodevelopmental disabilities. Okay, and neither is the facial anomalies. Okay, so these will have a lot of relevance when we talk about how we evaluate and how we diagnose FASD. So hopefully this is kind of like a nice table for you all to be able to see if any of the, if you have a child, if you're working with a client, or if you are thinking of a client like, my client could have FASD. These are some of the things to kind of like to start thinking as to which of the diagnoses under the FASD umbrella that they could fit. So in terms of some of these diagnostic features, I've shown this in all in other trainings as well, but for those of you who are new and joining today, wanted to show you also a visual of the facial features. As I said, we only measure the 3 as the most determining facial features that I mentioned as the small eyes. As you can see, the eyes, small eye openings, and then the epicanthal folds there that kind of leads to that smaller eye openings. And then we have the smooth philtrum. As you can see, it's where it's located. As you can see, there is no bump. It's very smooth because alcohol impacts the midline of the body and the face. So everything in the midline is going to be more flattened and not as developed. And then you can see the thin upper lip. But there are also some other facial features that are characteristics of FASD, and that's why I also wanted to show you, which we mentioned as the smaller head, the microcephaly. We have a low nasal bridge. As you can see, there is really no bump on that nasal bridge. And then we have that flat mid-face. As I mentioned, alcohol impacts the midline. Therefore, no cheekbones. It's just pretty flat mid-face. The nose is pretty short. And then we also see the underdeveloped jaw that could be very much characteristics of FAS. Okay, so with these facial features, if they are present, it can differentiate those with FAS, which is the fetal alcohol syndrome, with 100% accuracy once they have all the 3 facial features. And at that point, we really even don't need confirmation of exposure, because without exposure, we do not see these facial features that are very specific to FASD. However, going back to my original point, which is many subsets, many individuals under the FASD umbrella will not show the presence of abnormal facial features, such as the alcohol-related neurodevelopmental disabilities. And therefore, those are the ones diagnostically will fall under the radar, and then those are the ones that will be misdiagnosed with other disorders along the way. And now today we'll talk about some ways how to prevent that. Another hot topic that I always get a lot of questions about is, okay, we need the presence for the diagnosis. We need the presence of prenatal alcohol exposure, right? Okay, so how do we get to measure prenatal alcohol exposure? Brown et al. In 2018 has a really great article that I would recommend, laid out a lot of the different ways that we can actually measure prenatal alcohol exposure. So some of the ways are we could do maternal surveys, interviews, we can engage in clinical observations. A really good way is to dig deep into the medical records. So if you find yourself in a position of evaluating or in the process of referral, it will be really helpful to look in very much detail to the medical records. Somewhere it could indicate that the mother consumed alcohol, was seen consuming alcohol during pregnancy. Okay, so those are some of the things that we could have. We could have our own clinical observations where we might have had contact with the birth mother, and those could be indicated in the reports as well. There are also some other ways. Some of these are called biomarkers of alcohol. Some of these are looking at the fluids such as the maternal blood, sweat, oral fluid, hair, placenta, the newborn's blood, urine, hair, or meconium. However, there is limited evidence to support these tools, and then the validity of these, just picking it up every time is not as well established as we would be able to do in drug exposure. As you all know, for babies who are drug exposed, can be screened right at birth and looking at their blood, and then alcohol will, drugs will show. But alcohol is not happening in the same manner. Okay, so therefore, at this point, we do not have the best methods to be able to nip it right at birth and say that this child was born with alcohol in their system. We do not have good procedures for that, unfortunately. So then how else can we do? We can also do self-report. However, we also know that the self-report has problems with validity in itself, in the sense that it's not an accurate measure of alcohol consumption due to underreporting. The birth mother may not want to disclose. There could be a recall bias. I will invite you to think what kinds of beverages or just any kind of fluids that you have consumed just yesterday. Just try and remember that. Just think for a second. And can we all remember everything that we drank, alcohol or non-alcohol, even yesterday? And now we are asking parents to remember that during pregnancy, okay? Or like a month ago when they got pregnant. So that's really, kicks that recall bias, and they may or may not be able to remember when exactly, at what trimester, how much they drank, whether they engaged in binge drinking or not, what was the type of liquor that they drank. So it's really difficult unless they had a diary or something where they put all of those down, which of course no one will do that. So that will become an issue. And there are also some other factors that influence the validity of the self-report. Think about a mother, a birth mother, being interviewed by a physician, okay? If the questions that are asked in a very biased way, in a way that would make the birth mother feel guilty about, what they have, what about their alcohol consumption, that they feel like they have done harm to their child, and if the questions are phrased and asked in a way to elicit that, and of course they will impact the responses. So therefore, the interview environment, the context of the interview, and how questions are asked will definitely make an impact on the validity of the self-report. Therefore, if you ever find yourself in a position of interviewing women, whether they're mothers yet or women of childbearing age, if you are asking about alcohol, there are really some great samples, and I know Dr. Chasnov also talked about some ways that he's put together some of his screeners for mothers to be or women of child bearing age. When you ask about alcohol consumption, in a very nice and a very appropriate way to be able to elicit the best responses. Okay, but I just wanted to mention that self-reports can be a difficulty. However, if done right, we could get some good information. So all in all, we have these tools and we have screeners to be able to get this information from the mothers, okay, to identify alcohol consumption in pregnancy. But just please know that they do not capture everyone at risk, okay, or nor do they provide information about frequency of consumption, when exactly they consumed, what was the concentration of the alcohol, what type of liquor, and so forth. And then the type of drinking, like binge type of drinking or once in a while, light, heavy. So we cannot really, through the screeners, all we can get is that they drank or not. Okay, that's why, because of all of these difficulties, research indicates that there is no appropriate amount of consumption, there is no appropriate amount or timing of consumption during pregnancy, because even one glass can make this whole impact that we're going to talk about, or more prolonged consumption. So therefore, there is no safe amount or timing of alcohol during pregnancy, and that's definitely, I always repeat it in every trainings, is the message in whatever capacity you might be working, whether you work with children with FASD, with developmental disabilities, or you work with their parents who might also bear future children. So I think this message is extremely important to convey and to give to all of those women that you might be working with together. I also wanted to talk a little bit more about what are some of the reasons that mothers would not want to share the information regarding alcohol exposure. And that's why we sometimes have difficulty with this part of the criteria diagnostically. And I'm sure some of you will have questions around that. So mothers also avoid disclosing information about whether they drank during pregnancy or not, and they provide minimal information about that alcohol consumption. And as a result of that, they might also not want to participate in some of the research regarding FASD either. Therefore, we might be not integrating them into the current research, and therefore we cannot always advance in that area either. Some of the reasons that I found out in the literature is negative stereotyping, as we can all imagine. If they are found to, or if they report that they're drinking, they fear that they might lose their children along the way because of the drinking piece. There could be, of course, fear of reprisal. There would be perceived kind of lack of benefit of detection of FAS. So this is something that I've also come across clinically as well, that I've heard from a lot of either providers or stakeholders, organizations as to, well, the impact has been done. Why do we need to diagnose FAS or anything under FASD? Well, the impact of the alcohol has been done, and then the client is struggling. We already know that. We cannot reverse these impacts. So what is the benefit of detection? Well, if we are face to face and live, but if we had a chance to interact, I would direct this question to you. So I would invite all of you to think for a second. What do you think is the benefit of having the diagnosis for FASD? So just give yourselves, a time to think as I move along. And I'll talk about, of course, the benefits in this training. Some other reasons why mothers would be reluctant to share alcohol consumption is, of course, guilt and embarrassment. So the very natural feelings that they would definitely have. And of course, we have the fear of stigmatization by others. saying that, oh, this person has drank during pregnancy and this is what happened to their child, and then being stigmatized in that manner where they would not be able to move forward with the treatments, with services, with their lives in general, and being very much burdened under that stigma, which of course prevents the family to have meaningful relationships, have a meaningful life moving forward. And of course, the child's apprehension. Sometimes when children are, of course, at an age where they do understand what FASD is, I've had a lot of interviews where the mothers requested, whether they were adoptive mothers or birth mothers, they requested that they speak with me alone during the developmental history piece, where they were going to talk about the alcohol exposure, because they did not want their children to know that they have been exposed to alcohol. They did not want to share that at that moment. So, of course, we respected that, but we also talked about the importance of sharing this information, that they do not hear it kind of from someone else, that they can kind of build this relationship together, work on their attachment, and so forth. However, that becomes an issue because it's not like when you share the diagnosis of autism with your child, and if the child tells you, why did I have autism? Is that something to do with this and that? Well, we can say it's genetic, right? But then with FASD, there's going to be an explanation about prenatal maternal alcohol consumption, and that not all families or parents are equipped or ready to have those conversations. Also, I invite you to also think about that piece more specifically. All right, I'm going to pause here a little bit to take some questions, because in the next section, I'm going to talk about different diagnostic systems. So that's another segment. So I think this is a good place to pause a little bit.
Hi, Dr. Ergen. The first question is, can you give some examples of how to sensitively ask those questions? I think to the birth.
Yes, to the birth mothers.
That's what I'm guessing.
Yes, okay. So in terms of, in general, if there is no, like if you're not doing an FASD type of, evaluation per se, okay, then we could ask about general, alcohol consumption, okay? So just like we would ask about drugs, alcohol, smoking, that's part of an, like an interview. So kind of like really mentioning about what kinds of, have you had, consumption of alcohol within the last, and you can just kind of like put a, timeline. Okay, just like they do in general in the physicians, offices, and asking, regarding not really like an amount and things like that, but whether they have, consumed, alcohol, and then you can add the drugs, you can add about, cigarettes as well, the smoking, and indicating that that is part of, if you're not doing specifically an FASD eval, that could be kind of like part of the general medical, evaluation, okay? And then if then they say like yes, then we could ask them as to if they were able to recall, when was the last time, for example, if they mentioned about the binge drinking, was the last time that they engaged in that, we could ask about that, and then we could kind of like cater and then just try to get a little bit more information if we are specifically doing an FASD evaluation to see which trimester and so forth. And of course, at that point, we'll all have to use, we're all clinicians in some way, we'll have to use our clinical skills regarding seeing if the client is uncomfortable. I've had to stop and pause and say, I feel that, you might be a little bit, apprehensive. Can we talk about that? And then they usually disclose or just kind of like say, I'm not really comfortable, about that piece, and I don't see how relevant that is to what we're talking about. And then I think that becomes a really nice conversation to see, yes, I can definitely understand your apprehension and worry. Can you tell me what some of the areas that that you worry about, to kind of like get in there and use a little bit of your motivational interviewing skills to get to the area that you'd like to talk about. If you are specifically doing an FASD evaluation, then we can say that confirmation of alcohol exposure is one of the criteria. So that's an important piece to indicate. And therefore, that we need to kind of like have that indicated and documented. Sometimes families or parents say they do not want that, specifically documented because they fear. We can also indicate that past use and exposure is not something that would necessitate involvement of children's services. Okay, so I think that's an important information to share from the get-go, because at the beginning of your interview, hopefully you shared that you are mandated reporter if there is a harm to the child, but that does not include prenatally. I think sometimes that's an information that parents don't know, and that makes them a little bit more nervous.
The next question.
So were there any other questions?
The next question is, I wonder if women are concerned, or concerned people will think they were addicts. Is this caused only by the level of alcohol consumption associated with addiction?
So if I'm understanding right, if the birth mothers would have a concern that if they disclose this, whether the physicians or the people who are interviewing them would think they're addicts? Is that?
It's hard for me to, Aubrey, can you clarify what you're asking? It says, I wonder if women are concerned people will think they were addicts. Is this caused by only the levels? I wonder if women are concerned people will think they were addicts.
Okay, if I'm understanding that correctly, and that's sometimes the difficulty with these is we can do back and forth with the person who asked the question, but yes, there is a lot of concern about that perception, and that's why I said the way the clinicians need to approach the birth mothers while they're interviewing is not at all stigmatizing. It's just for getting this information because this is part of the criteria. We'll put that aside as there was consumption. After that, we're not really worried about how much and so forth, because we will move forward with our evaluation, which will give us the answer and the diagnosis. We are not really concerned more about how much the mom drank and so forth, because we really don't have a good way of knowing and teasing that out. All we need is that, was there alcohol consumption or not? So if we cater our approach that way, that this is one box that needs to be checked, after that, we're not worried about the mother. We're worried about the symptoms and the presentation of the child.
So she's asking if someone tells a teacher if their kid has FASD, they may be worried someone thinks they're addicted.
Okay, yeah, that's definitely a concern, and that's the part I mentioned about the child apprehension piece. So that's definitely a difficult area to, manage. We have to have conversations, with the children when we give the diagnosis, and then it's the job of course, the psychologist who does the evaluation, or along with the team, to give this news to the child as well, and then to we could kind of like have those conversations with the mother, preparing the child together that time when she was pregnant and when she was using alcohol at that point. This probably was a difficult time for the parent, for the mom, and after that, currently there is no use of alcohol. Things are in order, so that doesn't make the parent an addict, but that just means that, just like maybe the parent had depression during pregnancy, it's just something similar. They were struggling, and then alcohol was the choice to deal with that struggle at the time, but that's it at that point. So there needs to be a lot of psychoeducation, and then stigma, and that's why in the last series, we're going to be talking about more specific ways as to how to decrease the stigma along the way.
And that's the end of the question so far.
All right, thank you, Karen. And thank you, Aubrey, for the good question. All right, so in the next part of my presentation, I will be talking about different diagnostic systems that are out there. So to start out with, what I'd like to say is that, unfortunately, and I'll say unfortunately, FASD is one neurodevelopmental disorder where we do not have an agreement on the exact way to diagnose this disorder. Okay, so we'll talk about what are the consequences of that, but all in all, we are in agreement to diagnose autism. We are in agreement to diagnose ADHD. With some nuances along the way. We have ICD-10, we have DSM-5, and so forth. But all in all, DSM-5 is just beginning to recognize FASD. But in general, we do not have a consensus, unfortunately, as to how to diagnose FASD. And we'll talk about why. But I wanted to first start out by introducing you different ways and different organizations that came up with criteria. And you might want to say like, okay, Dr. Argun, why do we need to know all of these? You are the person, or you all who are doing the assessments or evaluations are the people who do the diagnosis anyways, and we don't know what you're doing really. We just get the reports and move along. Well, that's not true. For those of you who have gone through a diagnostic evaluation for your child, okay, your birth child or adopted child, foster child, or who has been part of this as a multidisciplinary, team, or you've been a teacher, you've been an advocate, and so forth, or a caregiver, you probably know how difficult it is to even seek this evaluation, go through this evaluation, get your results, and then try to understand how this evaluation was put together. So this is to empower, this is to strengthen your knowledge if you are going to be finding yourself along this journey. And I call it a journey because it really is a journey. It is not as easy as, oh, I got my child diagnosed with ADHD or learning disabilities. This is not an easy path just like that. And that's why I wanted to talk about these different ways that we have right now to diagnose. Although I'm going to talk about commonalities, I just want you to know as a knowledge and understand that we do not have conformity and a convergence in terms of our diagnostic tools and methods. The first one was Institute of Medicine, IOM. Criteria was developed in 1996, and then it was later on updated in 2005 and 2016. But all in all, and I'm going to talk about how that goes, but it was criticized for lacking criteria for the actual diagnostic kind of like criteria, where they didn't really give a whole lot of definitions for alcohol-related neurodevelopmental disorders. So the lower, kind of like the less severe form of the FASD. And they also use the term partial FAS, which we do not use anymore. Okay, so the field did away with the partial as far as I'm sorry, not the partial, but just the fetal alcohol effects. Okay, and they also did not really document whole about the family or the genetic history. As we know, there are a lot of other syndromes that also resemble in terms of the facial features or the genetic makeup of FASD. Therefore, anyone going through an evaluation for FASD really needs to see someone in the genetic department, genetic counselor, geneticists, and they have to have that evaluation just to make sure that what we are seeing is not other genetic disorder, which could resemble FASD as well. Okay. So what is the IOM criteria? First of all, we have to have confirmed alcohol exposure. That would be in an excessive form. Or they also said that, if we cannot know it, then it may be unknown as well. pre or growth. So when we say pre or postnatal, it can be prenatally measuring small, or postnatally after they're born, the growth in terms of height and weight is going to be below 10th percentile. So what we say is that there is a growth impairment. And then what they want as part of their criteria for diagnosis is at least 2 of the 3 facial features present. And we said that's the small eyes, smooth filled room, and the thin upper lip. IOM only requires 2 of the 3 facial, unlike the other criteria, unlike the other diagnostic systems. And then we need to have the head circumference less than the 10th percentile, and they say or recurrent non-febrile seizures, okay, or cognitive impairment in any of the domains that is equal or greater than 1.5 standard deviation below the mean, okay. So this one is different in the sense that we only have 2 of the 3 facial features. We have confirmed or unknown exposure, and then we have the pre and postnatal growth and issues, and then we have either the head circumference seizures or cognitive impairment. So to me, the IOM criteria really more favors the FAS diagnosis, as you can see, right? If a child does not have the facial features, doesn't have the growth impairments, which we said a lot of them don't have, then all it relies on this, the cognitive impairment, that's 1.5 standard deviation below the mean. So under this, then what are some of the diagnoses that we can have? As I mentioned at the beginning, we have fetal alcohol syndrome. This is the full-blown syndrome, which is the more severe form of FASD. And it's the leading cause of cognitive impairment. So usually if a child has FAS, that means that the mother drank heavily starting from the beginning of pregnancy till the end, and there was heavy chronic alcohol consumption. And as we know, it's entirely preventable. So what are some of the diagnostic criteria for a child to qualify to have an FAS? It's characterized by the growth impairment that we mentioned, current or past, weight, because a lot of the children, if they are placed in a stable home, their height and weight, that kind of keeps improving, right? So once they are born, and if they're in a good environment where they're going to be nourished, well-fed, and cared for, then they do not show the height and weight impairments. Okay, so it can be just the past too, so that we can capture those. The facial dysmorphology, the 3 ones, and then we need to have a central nervous system damage. It can be a structural damage, okay, such as head circumference. It can be a neurological, such as the seizures, or it can be functional impairments, such as memory, learning, executive functioning, and so forth, all of those deficits. And we need to have, of course, prenatal alcohol exposure. That's confirmed. So when 4 of those are confirmed, we have the most severe form, and we can then reliably diagnose fetal alcohol syndrome. Then we have what we call partial FAS. In the partial FAS, this is a diagnostic classification under FASD. Now we need to have prenatal alcohol exposure again. We need to have the central nervous system damage that we talked about, which is the functional impairments. And then we need to have most but not all of the growth deficiencies or facial features. So a child might have 2 of the facial features, maybe have weight under 10th percentile. So what we're seeing here is they could have a intact or typical head circumference, they could have a normal height, they could have a low weight, and maybe 2 of the facial features. That means that they do not have the full-blown FAS, but they have partial FAS. So what we're seeing here is not the full-blown physical impairments, some of the physical impairments, plus still the central nervous system damage, and then the prenatal, of course, alcohol exposure. So as you can see, we're going from the spectrum of more severe to a little less severe. And then the next one is what we call alcohol-related neurodevelopmental disability disorders. So this was a diagnostic classification that was named by the Institute of Medicine in 1996 to capture those children who were not impacted severely during pregnancy, but for sure they had prenatal alcohol exposure. However, possibly the mother did not drink during the first or second trimester, but drank more heavily in the third trimester, where we see a rapid brain development. Therefore, we for sure see central nervous system damage, meaning that alcohol impacted the development of the brain and the central nervous system during the last trimester. Therefore, we heavily see issues of behavioral dysregulation. We see issues around memory, learning, processing, sensory difficulties, maybe impacting a little bit of IQ and cognition, severe learning difficulties, and so forth. So we definitely see central nervous system damage. However, what we do not see is we don't see facial features, and we really don't see growth-related issues. So they will have no facial features. They will not have height, weight, head circumference issues. They will not have accompanying seizures or any neurological problems. Then it's named as alcohol-related neurodevelopmental disorders. So what this one is basically telling us is that alcohol has made an impact on the brain, which leads to some developmental delays and some neurodevelopmental difficulties that we see, but it's not as extreme as if the mother drank throughout the whole pregnancy. And then the last, which is the more rare form, is alcohol-related birth defects. In this one, we see more impact on the formation of the organs. So, which tells me that there was more exposure in kind of like the second trimester around, where the body, the organs are kind of forming, okay? So we see more problems like as heart issues, murmurs, bones, kidney problems. We see a lot of vision related issues. We see some hearing problems. So a lot more physical problems than facial features or more of the cognitive issues. So the first one was the Institute of Medicine that kind of like paved the way for the initial explanation of the symptoms and putting them together to help clinicians to diagnose. And then later on, we see the Centers for Disease Control, CDC Guidelines, developed in 2002. The US Congress mandated CDC to develop guidelines for diagnosis of FAS to be put in the medical guidelines and the medical school curriculums, and then also to be recognized by professional organizations and accredited boards. So before this, it was medical curriculums as far as for medical students to even learn ways to diagnose FAS. So in that sense, that's a good step and a good development. But as you can see, it's still in the 2000s, so it's still kind of like very recent that it was kind of integrated into the medical field. So overall, some of the problems with the CDC guidelines was that they really only focus on FAS. So if you go back to the medical curriculums, you will not see anything on RAND. And then I could see some of you, definitely some of you that I also interacted with, saying like, Dr. Ergun, that's so true. When I tried to go and explain that my child could have RAND, the doctors kind of looked at me like they're not really sure what I'm talking about. That's the reason, because it's not in the medical curriculum. They are not learning about the less severe forms of FASD. And when I do my grand rounds, I've done a few of those in children's to the residents. That was really the first time that they were hearing about the RAND, and they sure knew about FAS, but they didn't know about the other forms and that it can actually be diagnosed. So that should not come as a surprise after learning about this information. So therefore, another information that I wanted to share is that with one of my doctoral level students, her dissertation is about pediatricians and physicians working with children and their knowledge and perception of FASD. And what we have found is that they know about FAS, but they do not know about the other diagnoses that I already shared with you under the FASD umbrella. Okay, and when it comes to diagnosing, they do not feel confident in diagnosis, and then they usually refer elsewhere, or they refer to other clinics. They do not make the appropriate referrals. So I think we also have a lot of work to do at the medical level to inform, and then kind of like trying to push these to be also integrated into the medical curriculum, where all of the doctors, pediatricians will be ready to tackle this from the get-go. Because guess who? Our children who start to have developmental delays or behavioral issues go to first? Yes, they're pediatricians. And if they're not equipped, they don't feel confident, then we're starting with a bad foot there, right? So, and another piece is that they did not accept the Institute of Medicine criteria. So really, they had a really general perception of FASD, and they just thought about it like, you have the facial features, there is the growth issues, then we have FAS, and that's what we can diagnose. Everything else, we really can't deal with much. Then came the very, currently widely used system, and some of you might be familiar with this system, 4-digit diagnostic code. This was developed in 1997 in University of Washington, in the state of Washington, the University of Washington being the champion, across 7 FAS clinics, and after that it was updated in 1999, and then after that in 2004. So this is also known as the 4-digit, diagnostic code. It uses 4 key common areas, and this is a very well accepted diagnostic system. It ranks these 4 areas that I'll be talking about on a 4-point Likert scale. Okay, so the 4 areas is not any different than what we talked about for the Institute of Medicine criteria, which is the growth deficiencies, facial features, brain development, which is the same as the central nervous system issues, and then the prenatal alcohol exposure. Okay, so this is a system that's currently used in the clinics both in US and very widely used in Canada. So as you can see, every client is evaluated as far as whether it's severe, moderate, mild, or non-existent in each of these categories. Okay, so this is done through a multidisciplinary team where the physicians, pediatricians look at the growth deficiencies, then they do measurements of the height, the weight, the head circumference, and then they come up with a rating. Okay, so as you can see, the higher the rating, the more high risk, and then the lower the rating, then less risk or no risk. Okay, and they do a really good job in terms of figuring out the facial features. I'm not going to go into the specific details of that. However, if you look at any of the 4-digit diagnostic code, they're also out there for public to see. They do take photographs of each client, and then they are evaluated specifically by the genetics department, and specific facial measurements are made where they actually measure the distance between the eyes, they actually measure the philtrum, they actually measure the thinness of the upper lip. So it's a very, very accurate and specific measurement that is conducted, which does give us a number on that Likert scale. And then prenatal alcohol exposure, also documented through the means that I already talked about. And then the brain development part and the impact on the brain is evaluated by either neuropsychologist or a psychologist who is well equipped in the area of FASD, where we document at least kind of like 3 areas that are within the below average range, 2 standard deviations or more. And when we say 2 standard deviations, if we think about the normal curve, if we are thinking, 100 is, like the mean, and then standard deviation is 15. For any of those tests and anything out there, 2 standard deviations would put us to 30 points. So 100 minus 30, that would be scores around 70 as far as standard scores or below would constitute as an area of impairment, meaning that the child is really struggling. They are far more below the average range in that area that's being assessed. For example, memory, learning, executive functioning, and so forth. Okay, so this, I really like the 4-digit diagnostic code and how it approaches. At the University of Minnesota Medical School in the FASD clinic, we use the 4-digit diagnostic code. We had our clients evaluated at the genetics department, and then we did the neuropsych evaluations. They wrote up a report, they sent it to us, we integrated their report into ours, and then we were able to evaluate the client on these axes, on this Likert scale, to be able to come to a conclusion. What is really nice about that 4-digit diagnostic code is that it has numerous codes that you can get, right? Someone could have number 2 and 3 and 4, someone could have all of them, someone could have 3 and 4. So we could have numerous combinations, and they also provide a very nice write-up for each of the possible combinations that are out there. Okay, so if there are any of you who are specifically interested in it's a huge big document, but if you find yourself interested, please send me an email. I'd be very happy to share that with you so you can actually see all those photographs, the way they do it. It's a very nice method. But then you can say, then if it's so good and it's so reliable, why cannot be that used all uniformly or universally? Well, it has been also criticized in the way that it's not very practical for real world applications, which a little bit I have to agree in the sense that it's very detailed, and unless there is a FASD clinic specifically, it might take a lot of time for just a developmental disabilities clinic to be able to utilize this. And then the clinic has to have a relationship with the genetics, because genetics has to be involved in the facial measurements, okay? And then a third one is you have to have that multidisciplinary team to engage in this piece. You cannot work in silo and use the 4-digit diagnostic code, because you need the help of the other departments as well. And as we know, funding is not available for all children's hospitals and so forth to have these multidisciplinary teams. Not even all hospitals have even like an autism clinic at this point in time. So FASD is more recently being recognized. Of course, the goal and aim is to have an increase in those clinics where also procedures or diagnostic methods like this can be more utilized. Let's talk about DSM-5, where a lot of the clinical psychologists do operate in, and when they have to bill, they usually bill based on ICD-10 or DSM-5. So currently DSM-5, under DSM-5, we can diagnose what we call other specified neurodevelopmental disorder associated with prenatal alcohol exposure. Okay, and I put the code down as well. So this is under the section for neurodevelopmental disorders, and it's named as a other specified neurodevelopmental disorders. It's on the same section where we can diagnose autism, ADHD, learning disabilities, language disorders, and so forth. It's at the very end of that chapter. So we need confirmation of alcohol exposure, and it's defined as more than minimal for this diagnosis. However, it can be diagnosed regardless of the presence or absence of physical effects of prenatal alcohol exposure. So what does that mean? Under DSM-5, if a child if a child did not get evaluated for physical facial features or for the physical impairments, if we can specify that they had central nervous system damage, and if we can confirm of alcohol exposure, they can be diagnosed with other specified neurodevelopmental disorder, which will be the equivalent of alcohol-related neurodevelopmental disorders. So for those of you who are wondering, how can I get my child the RAND diagnosis, because they probably have it because they don't have the facial features, under the DSM-5 we can, unless we have a confirmation of the alcohol exposure. Okay. So what are then the criticisms of DSM-5? Well, DSM-5 does not differentiate between FAS, the partial FAS, RAND, and so forth. It just gives this one diagnosis. And so then you can tell, Dr. Argan, how do you go about using DSM-4? You are a psychologist. How do you get to diagnose? Well, what I do is that I use this code if my evaluation indicates that the client is somewhere under the spectrum of FASD, and I put this code, and then I send my patient for genetics to get the facial measurements, and then to their developmental pediatrician to get the measurement for the physical, the growth part. If they show both of those, then I still use this code. And then in my summary, I indicate that the client shows impairments in the following domains, but also has been documented to have facial features as indicated by this doctor's report. And I add that report to my summary. And then, therefore, the child presents with fetal alcohol syndrome. Okay. However, by DSM-5, there is no code for me to indicate that it's FAS, but I put it in my summary. So because if the family needs services or other things, that at least it's documented in the summary section of the psychological evaluation report. Okay. So I just wanted to lay out specifically how I go about diagnosing, and then how I portray the level or the spectrum under the FASD, because it's not specifically captured under DSM-5. So as I said, DSM-5 does not capture any subtypes. Okay, it doesn't care if it's FAS, RAND, partial, and so forth. It just says that there is a neurodevelopmental disorder that is due to alcohol exposure. That's all it indicates. And then the functional deficits have to be, again, 2 standard deviations below the mean in each of the following domains, which is neurocognitive, which means memory, learning, motor, visual, spatial, and so forth. The next one is in self-regulation. So this could be in an area of attention deficits, inattention, hyperactivity, impulsivity, dysregulation. And then the third one has to be in the area of adaptive behaviors, which could be daily living skills, dressing, eating, navigating themselves in the community, and so forth. So all of those adaptive deficits that we can evidence and show that it's 2 standard deviations below the mean, then we can evidence then the central nervous system abnormalities by DSM-5. One good news is that if you look at the back of DSM-5, there is a section under the further study. There is a whole FASD as its own separate diagnosis. So my hope is if the next iteration, if everything goes right and the right political and the people in the psychiatry and the medical world are rooting for it, which I hope so, then in the next iteration of DSM, then we will call it the revision one or the 6th one, then we will hopefully see FASD as a standalone disorder, just like any of the disorders out there. And then it has this very nice, criteria. However, even I think that those criteria need some work, because it doesn't also still recognize the subtypes. It just says it as all of these specific areas, exposure, and so forth. It probably needs to have some kind of severity indication there as well, but I didn't see it there yet. So hopefully some folks are working on pushing that into DSM, the next iteration of DSM, so that we can actually have a name finally for it to be recognized in the psychiatric world as well. All right, the next one is ICD-10. Again, I'm not very optimistic about the ICD-10 depiction in the diagnostic system. There are many codes in there. I just put a few. I think there are around 8 to 10 codes. And again, for those who are interested, I can send those along the way. But again, they capture more the FAS. As you can see, FAS gets a lot more attention in the medical world. When there is dysmorphic, for the facial features, you can easily get that diagnosis. And then as a newborn, if they are suspected to be, or there is an alcohol use of alcohol and so forth, then they can go ahead and capture it that way. And then the most frequent, that's the one I didn't include here, but the most frequent ICD-10 diagnosis that I've seen is static encephalopathy. Okay, that means that there are some impairments in the brain functioning, but there is no mention of alcohol. It doesn't attach it to alcohol in the name of the diagnosis. So that's why I'm not as in favor of that. It just because static encephalopathy can also occur due to many other reasons. Okay, so however, if there is a neuropsychological evaluation, and then if you see that the child got that diagnosis, that's also a way to go, to be able to get that diagnosis. And you can also talk with your providers if they are operating under ICD-10, if there is exposure, and they can document all the neurocognitive impairments. They can also get that diagnosis, and then that could hopefully pave the way for some more appropriate interventions. And then the last guideline that I wanted to talk about is the Canadian guidelines for FASD. So in this one, it was developed in 2005 and revised in 2015 by Public Health Agency of Canada's National Advisory Committee on FASD. This is really good. I'm really in favor of this, but of course, this is a Canadian guideline. This is not US. It combined the 4-digit diagnostic code and Institute of Medicine. So to me, like best of the two, both worlds. Okay, so why I like this one kind of like over the other ones is that because of the way that they combined. It mentions that the comprehensive evaluation for FASD, for a diagnosis, has to be done by a multidisciplinary team. It kind of spells it out like that, which is really nice for a more evidence-based diagnosis. And then it indicates that we need to have a neurobehavioral assessment. So for all of those cases where we say, we just look at the facial measurements, growth, and then we'll be done. No, we can't stop there, because if we don't find it, what happens to all of our children who don't have the physical part of it, right? So the Canadian guidelines indicate that we need to do the neurobehavioral assessment regardless. Okay, so that's the good part. And it does a really good job of how we can analyze and document maternal alcohol history. Okay, so it gives us really nice examples of how we can elicit this information, because I'm sure some of you will give me examples like, well, Dr. Argun, we know there was exposure, but we cannot document it because there is no way it's documented. It's not anywhere. So what should we do for those children? Because that is one criteria that is prevalent and needs to be there across all diagnostic systems. Without that, we can't really kind of like get started. Okay. And then the last part that I really like this one for is differential diagnosis. And I plan to talk about that today because FAS. So therefore, the presentation of FASD resembles many other neurodevelopmental disorders. Therefore, there is a high rate, up to 80%, of missed diagnosis or misdiagnosis, which I'll talk about. And none of the diagnostic systems really say that, hey, you really need to go and do a good job of differential diagnosis so that you do not mistake an FASD with another neurodevelopmental disorder. Okay, so to me, this is the best of the both worlds. And how I operate as a psychologist who does a lot of FASD evaluations is I don't have the luxury to work with a multidisciplinary team. However, I collaborate with the genetics department at Dayton Children's to send for the facial measurements. And then whoever is the pediatrician or the physician of the child, I send that for the physical part. I do the neurobehavioral assessment, myself. If needed, I send for speech and language evaluation. But I do my best. That's why my evaluations are pretty long. I do, I think, a pretty good job with the differential diagnosis, so that when I finally give this very important diagnosis, I for sure know that it's not autism. I for sure know that it's not another diagnosis. So any psychologist who is wanting to do an FASD evaluation should really be equipped well with the skills for a good differential diagnosis. So I'll stop here again before I move on to another topic, which is talking about why having these discrepancies in these diagnostic tools is not serving us well. And I want to talk about a couple of research out there. I wanted to stop and get some more questions about these different diagnostic systems. Karen, are there any questions?
Yes, there are, Dr. Gergen.
Okay.
We have like about 4 questions. The
Mhm.
first one is, do you think that women who drink recreationally may unknowingly be drinking during pregnancy until their pregnancy is confirmed? Do you think that women are educated enough about the impact of alcohol upon their children in utero? So that's like 2 questions.
That's a very, yes. Maybe I'll have to have you repeat the first one, but the second part was, I do not think that women are well equipped from the public, from the government messages, from the messages and recommendations from the physicians, their OBGYN, regarding the harmful effects of alcohol. A lot of the women, when I last presented at, was at the women's jail, ORW, I asked, there were around 300 women, and they were, a lot of them were of childbearing age, and some of them were mothers. I asked them what they thought if they knew alcohol could, pass through the placenta and have any harmful effects on the baby. Okay, it was half and half. All right. And then you might say, well, that could be due to SES and education and so forth. It's not any different. We still have a long ways to go to have this information more systematically shared, both through media, through campaigns, through education at the school level, at the high school level, maybe in the Alcohol Awareness Week, during those times, integrated into the curriculum for medical school and other, curriculums. So we have a long ways to go for some of the OBGYNs still not saying like, oh, 1 glass of white wine, would not hurt, would not do a whole lot. If you just drink it once in a while to relax you, that's okay. I've even heard things like, during labor, you can do that so that you can be relaxed. Okay, so I do not think that we are there yet in terms of knowing the harmful effects. And would you maybe mind repeating the first question? You were cutting a little bit, so I couldn't hear the whole thing.
Yeah, sure. Do you think that women who drink recreationally may unknowingly be drinking during pregnancy until their pregnancy is confirmed?
Yes, that is also a big issue. What research shows, I had research down here somewhere that kind of like indicated that a lot of that they are, and I'm kind of looking back at some pregnant on my notes, they do not know that they're pregnant until they are 6 weeks. Okay, and 45% of the women reported using alcohol in the 3 months before they were pregnant. Okay, so that kind of like indicates that a lot of the women are not realizing that they're pregnant and they are continuing to drink. So of course that leads to, remember we said the first trimester? Well, within the first trimester, until they figure out, we're halfway through the first trimester. 6 weeks means half of the trimester, right? The first one. So therefore, the message, I think, needs to be expanded to, if you are pregnant or you are, you know, trying to get pregnant, and then also at childbearing age. That's, I think, you know, if you are going to engage in sexual, you know, activity, hand in hand together, but refraining from alcohol and giving that message is also very important. So what we can say is that, yes, we know that they do not want to do any harm, and they just don't know simply that they're, you know, pregnant. However, a lot of the women do stop once they figure out that they're pregnant.
Next question.
Mhm.
Can you review what systems are impacted by alcohol use in specific months of pregnancy?
Like the impacts? Sure. So as far as for the first trimester, if there is alcohol, continuous alcohol use throughout the first trimester, which is the first 12 weeks, if that's when the neural tube closes, and that's when we will see the impact on the facial features, because that's when we see the beginnings of the formation of the organs. Okay, so if there is alcohol consumption in the first trimester, then we will see facial features that I talked about. If there is continuous consumption in the second trimester, then what we will see is also some of the birth defects that I mentioned, because that's when we see the more development of the internal organs, such as the heart and the eyes and the ears, and they all take shape. And as a result of that impact on the midline, then of course heart and lungs and you know, all of those areas get impacted, and then we see a lot of birth defects. And on the last trimester is when there is a rapid brain development, where we see tons of proliferation of the neurons in the brain, which is the brain cells. Therefore, what we see is that if there is consumption on the third trimester, even more heavily, then some of the neurons in the brain die. And as a result of that, the baby is born with a smaller head, which there is a reduced brain volume in the brain. And reduced brain volume means less connections, less pathways. The brain is smoother. Our brains have to be wrinkly, right? A lot of, you know, wrinkles, and those are the pathways that helps us with processing information. So the brain becomes more smooth. So the more consumption in the last trimester, then we will see a lot more central nervous system impairments.
Next question.
Mm-hmm.
Can a mental health licensed professional diagnose FAS?
I'm sorry, who?
Can a mental health licensed professional diagnose FAS?
Mental health professional, I'm thinking maybe the question was around like a counselor or a mental health therapist, like at the master's level, right? It will not be possible due to just this reason. Only psychologists who, either school psychologists who have been trained in the area, clinical neuropsychologists, they get the doctoral training that is required to conduct assessment. And this is one area where we have to look at cognitive assessment, like you have to know how to give an IQ test. You have to know how to give a memory or learning test. You have to know how to give a neuropsychological test. Mental health professionals who are at the master's level do not get that specific training, and therefore would not be, you know, equipped for that part. However, they are equipped to do the interview with the parent. They are equipped to give like the rating scales and so forth. So they can definitely be part of the team, and they can play an instrumental role in sensitive questions and building rapport with the family, giving the rating scales and so forth. But then the testing part needs to be conducted by a psychologist specifically trained to, in the area of FASD.
Next question. Are there any DNA markers for FASD?
Currently, not that I know of at this point for the DNA markers, but I know that there are a lot of studies that are being done. I know there are a lot of studies that are being done at the imaging level. So they're trying both for autism and FASD. They are trying to see if they can reduce the time for diagnosis to see what brain structural or functional there are before we can give any tests to a child, right? Maybe at the 18-month, marker and so forth. I know there are a lot of studies underway that show like MRI studies that kind of show some of those structural differences. So maybe not at that, DNA, piece, but more after the child is born to look at the impact on the brain, because before they're born, we cannot really do anything. And after that, it's not really in their DNA. This is not genetic or chromosomal. This is directly the impact on the brain as the baby is in utero. Therefore, the DNA piece is not going to help us at all.
Okay, the next question is just a sec. Tracy Jackson has a question. She wants to know, just a second. She's wondering, does Dr. Ergen know when DSM-5 was last revised? And the second is, does she know when it will be revised again?
Okay, so it was just on the top of my head, I think 2013. That's when DSM-5 came around. I have not heard when the next iteration is, and if we haven't heard, it's either not being shared at this moment, but it probably usually takes around 10 to 15 years for a new iteration. So if you look at maybe even a 10 years, sometimes they do a revision, like the DSM-4 was revised, and that is kind of like shorter time. If they want to add certain things, they can just revise it instead of doing a whole reiteration. So maybe we can see, but we never know when that's kind of like announced as that there is going to be a revision or not. And when there is a rumor, something out there, we all know, but we haven't heard anything around that so far. A lot of the studies and research is still being based on that DSM-5. We still have some diagnosis in there that we have to establish their validity. So a lot of the studies are really focusing on utilizing the DSM-5 at this point before we move on to the next iteration.
Next question. How can I tell if a child has comorbidity of ASD and FASD?
Okay, I'm going to talk about that. So if our audience can hang on tight, I have that slides and I'm going to talk over that one. I have a specific one for that, so I'm glad for that.
Is the amount of drinking directly related to the severity of the disorder?
Drinking is definitely related to the severity, and there are different factors that go into that. First of all, timing of the drinking, okay? And I already explained what happens in the first, second, third trimester. So that's one, timing. Second, amount, how much the mother drank during the pregnancy. So it could be that the mother didn't drink anything and then hit a really bad mark, like had been abused, had trauma, divorce, so like kind of like really traumatic going on, and then started drinking, but then started drinking heavily. So that can make an impact. Or binge drinking. So the form of drinking is also really important. Both binge drinking and heavy consumption, chronic consumption, those are the two most harmful that determines the severity. Okay, and then there were some other factors that were found to be impactful on the severity other than these three, which are mother's support system, okay, mother's nutrition as they're drinking, because we know that for those of you who've been working with individuals with substance abuse, if an individual has a good diet, that can kind of like offset the impact of alcohol on the body and the brain. So if there is a good diet, then it can kind of like lessen the severity on the baby. However, if a mother is drinking heavily and then also has a bad nutrition and a bad diet, then it exasperates things. Okay. And another piece is, as I said, social support and comorbidity of other mental health problems. If a mother already has like PTSD, has been traumatized and abused, and has substance use issues, not a good diet, and let's say a single parent, lots of financial issues, and drinking, and is pregnant. So this is the worst kind of like scenario of all of the things that could go, together that would create more severe presentations. So therefore, even though some of you might say like, well, the OBGYN figures out the mother is drinking during pregnancy, what can they do? The sooner, it's like the smoking, the sooner you stop, the better the results, meaning that the severity will be less. So any of you can be instrumental in having a pregnant mom stop drinking at any time. It's going to be helpful. Okay.
The second part of Michelle Wage's question is, she said, how does a mother who has one or two large binges with large amounts of alcohol compare to someone who drinks often but only a small amount?
Okay, that's a great question. So literature research shows that binge drinking is really harmful to the baby, and that's indicated in the literature for FASD, as opposed to not doing the binge, drinking and then drinking more in smaller amounts, but more kind of like periodically. And then the reason for the binge drinking to be more detrimental is that all of a sudden the amount of alcohol that floods the brain is way too much than the unborn baby's brain to handle. Okay, in smaller doses, again, it's very harmful and it should not be done, but if it gets in smaller doses, at least the brain has a little bit of timeline to process it as much as it can. It's still very harmful. However, when there is binge drinking, it means that the amount that the brain needs to be exposed is so much that it definitely leads to death of the neurons much more quickly, and therefore will have more severe outcomes when the baby is born.
Okay. Aubrey Page wants to know, can you rule out FASD using an MRI?
For that one, that's a good question, Aubrey. And I did not review those studies, for this, presentation specifically, but one of my mentors, Dr. Wozniak at University of Minnesota Medical School, did a study on that. If you're interested, I'm happy to share that with you. It does indicate that that they can see the signs, the impact and the damage in the brain using MRI. However, the MRI does not help us to rule out other neurodevelopmental disorders that might be comorbid, or it doesn't help us to determine if the individual also has other comorbid conditions such as ID, ADHD, and so forth. We cannot see that. All we can see is that there is definitely damage. So we can do a global one saying this client has no damage versus this client has damage, but we cannot determine the severity. We cannot determine the comorbid conditions with that only. Therefore, the client still needs an evaluation for the specific, diagnosis.
Okay.
Therefore, it's not an evidence-based, diagnostic method at this time.
This question is coming from Sister Suzette Fisher. She said, I think it's a statement. She said, this is the first time I heard that psychologists can make the diagnosis. We have a team and the MD makes the final diagnosis and signs the report. What is your thinking? So you're saying a neuropsychologist or psychologist can make the diagnosis?
That's a great question, and thanks for posing that, Sister Suzette. And good to have you here. So what I was saying is that a psychologist is part of the multidisciplinary team, and is instrumental in conducting the the neuropsychological part of the evaluation. Without the doctor's part, our part is only one. Okay, so if we are not working with the doctors and putting the information together, then of course we cannot, because as I mentioned at the beginning, the evidence-based approach is multidisciplinary approach, just like you have, in your clinic. Therefore, the doctor by themselves, without having the psychological part, they can't diagnose unless it's just FAS. Okay, so however, the psychologist can't diagnose by themselves either. My response to our audience when they said, can the mental health counselors do that? I was just referring to that mental health counselors cannot engage in psychological testing, therefore cannot be, I'm not saying they can't be part of the team, but I'm saying they cannot provide the neuropsychological assessment. That's the only part that I was saying. But standalone psychologists will not be able to unless they work together with the doctors, and along with the doctor's reports, then the psychologist is able to. However, that's the other piece that I was going to talk about in the next part of the presentation, is there are a lot of discrepancies in the diagnostic tools and in the diagnostic approach. So I can see that in your clinic, the person who signs off of the diagnosis is the physician. Okay. In the clinics that I worked at University of Minnesota Medical School, FASD clinic, the licensed psychologist signed off on the report, but they integrated the genetics and the physician's reports into their report and finalized it together. So in that sense, the literature or the research does not say that one person can engage. They only say is who can engage in what part of the evaluation and who is equipped to do which part of the evaluation. But all in all, this is a multidisciplinary approach, and not one person can engage in the diagnosis by themselves without the part of the others. Hopefully that makes sense to clarify.
And the next one, Dr. Ergin, is more like a statement from Christy Hannon. She says, the recent inclusion of other categories of FASD helps explain why only FAS is on Ohio's diagnosis list for early intervention. And she goes on to say further down, she says, to clarify my comment, recent inclusion in the CDC guidelines, meaning other categories aren't in medical curriculum.
So that could be a reason why, and I'm not as well versed maybe as the audience into the early intervention system to see which one is included. So it sounds like it's just the FAS. So I think with that it should be kind of like expanded to the other diagnosis under FASD, and I think that's why we're doing all of these different trainings and so forth to also advocate for those to be included, because when they're not, it's almost like it's not there. And if a child does not have the facial features but is somewhere on the FASD umbrella, it's almost like they're not seen. And therefore, that's why FASD is also referred to as invisible disability, because if you don't have the FAS or the facial features, it's like you're not considered to have FASD, because it's not as much as, recognized in the the CDC guidelines, or just like the at Ohio, for the early intervention and so forth. So there are a lot of things to be done at the systemic level too, to be able to kind of like make sure that we can capture all of the nuances in the under FASD, and we do not leave a bunch of our children or individuals behind just because they don't fit into that FAS part. So you're right in your statement.
And one last comment from Aubrey Page. She says, I have a point of contact with DD on getting the state updated to include all of FASD. That should include early intervention.
Wow, that's wonderful, Aubrey. That's one of your great initiations, sounds like. And I'd be very happy to, if I can be of help to talk about that, or showcase, advocate. I'm just kind of like happy to work with you on that too. I think that will benefit so much a lot of our children who don't fit the one criteria there, just like FAS, so that it can be accepted. And then, like the other audiences mentioned, now they can select other diagnoses too to provide these early interventions, which is very vital. So that's a wonderful initiative, Aubrey.
And that would conclude all the questions we have thus far.
Okay, thank you. Those are wonderful questions, and hope I was able to provide your answers. And as a result of what I said, if you have follow-up questions, please feel free to add them in, and I'm happy to, because normally in a more face-to-face, then I would be able to follow up and making sure the questions were answered. So I'd love to if you continue some of that conversation throughout the questions as well. All right. So as you can see, we've got a lot of discrepancies in our diagnostic tools. Colas et al. In 2016 did a study on 1,581 patients and looked at their evaluations that they got and compared the 5 methods to diagnose FASD. And they found lots of differences in the diagnostic systems used. Okay. So that means that not one individual who was evaluated had the same diagnostic system used to arrive to the same diagnosis. So that led to that inconsistency among the diagnostic systems. So then we can ask ourselves, why are there these differences? Why can't we agree on one tool? One is that we are operating from the angle of different disciplines. Okay, so DSM-5 is all put together by psychiatry involved. CDC as well as Institute of Medicine has more of the medical model. We also have involvement of different countries, as you can see the Canadian guideline. We have the American ones that are out there, so we have different countries, and then we have also different positions of the governments and how they view just from the CDC versus some of the things that are done in Canada, which are much more advanced at this point, and then they more understand the nuances of the different diagnoses under the FASD umbrella. And there are also different levels of specificity in the definition of FASD, as well as differences in what constitutes a normal physical measurement. The reference data that's used is also different based on the different diagnostic tools. So what happens, and why did I highlight this? The reason why I wanted to highlight this is we have some negative consequences for the outcomes for having different diagnostic systems. The first one is we end up having an inappropriate, patient care, because if we are operating under a certain system and that system disregards the different diagnoses under the umbrella and just focuses on FAS, and if the child does not have FAS but has RAND, then what we are doing is we're leaving that child without a diagnosis, maybe with a diagnosis of ADHD, ID. Well, that will not provide the appropriate care and treatment. Therefore, we will provide an inappropriate treatment to a child who has RAND but cannot be labeled so or given that diagnosis, and therefore will be deprived of appropriate interventions. It also leads to inconsistent government messaging. If we are not in agreement, like overall for autism, we are all in agreement. We can say it needs to be screened at 18 months to 24 months. All pediatricians screen for autism. And then when they are, if we have suspicions, we know who to refer to. They're autism clinics. And then these are some evidence-based interventions, starting with speech, OT, ABA, and so forth. So it's very out there. We say it's genetic, it's not caused by vaccine. So we have a lot of agreements on other neurodevelopmental disorders as a more government level, but we do not really have that for FASD, unfortunately. It also, of course, leads to risk of secondary disabilities, which means that the primary disabilities, if they are not detected, identified, and treated, they lead to compilation of other disabilities and other problems, which we call secondary disabilities, which exasperates the severity of the ongoing issues and becomes a lot more of a burden on the caregiver and on the client. It also leads to missed opportunities at the prevention level, which means that as we all are here because we're also interested in prevention. But if we cannot decide on the ultimate diagnosis, okay, then we really cannot be forceful in our efforts for prevention either, because we cannot be all together. Like we can't even say who diagnoses FASD or not. We can't even, specifically agree on those, areas for sure. It also leads to missed and misdiagnosis, which I'll also mention a little bit. And then it also leads imprecision around the true understanding, the true economic and social impact and the cost of FASD. And why do we want to be bothered? When I talk about cost, I'm also always wary about that, because my reason is not saying that it's costly. All disorders, all medical disorders are costly, right? The reason is, how can we engage in better prevention? But another reason is that unless we know that it is also an economic burden, then that's when politicians and other stakeholders start to listen. That's the reason why. Otherwise, for me, we are all neurodivergent, and then individuals who might not fit into the typical presentation, we will make the environment fit for everyone's needs, and that's my approach. However, I mentioned the cost just because that's when we can get the attention of some stakeholders to be able to make some of these changes that Aubrey and others, are always, in our committee, are diligently working on to make changes at the legislative level. There was also another study by Clarin et al. In 2015. And what they looked at is over 15% of people diagnosed with FASD had discrepancies between their diagnosis and how they were described in their summaries, in the reports that are used to justify the diagnosis. Overall, people were not indicating what diagnostic system they use. So it was really hard to see, okay, well, how did you come out with your diagnosis? What was your approach? Or when you go to a clinic, and Sister Suzette would know that they have an approach. They can tell you what is their procedure, how they approach it, and what are the areas that they assess and look at, and what diagnostic system they use. So these have to be extremely clear in the reports. Otherwise, the people who are reading them later on, they could be confused as to how this team arrived to their diagnosis. Okay. And then that led to investigating, do the clinicians know and understand FASD enough? And what they found is that in general, clinicians also misunderstand and misremember what they stated as a diagnosis. they're not really firm on their diagnostic rules, or had a tendency to stretch them to cover some of the borderline, almost like they could lump them into a category and say like, yeah, there is alcohol exposure, and yes, there is FASD. But not all alcohol exposure also leads to this diagnosis, and that's why we need not the medical part, but that's why we need the assessment, the neuropsychological assessment part, to see if there is an impact on the central nervous system. That's why psychology is an integral part of this evaluation. And I also mentioned about the cost, and then the key, the important pieces for prevention already. So what are some of the recommendations that are out there for a diagnosis of FASD? Again, I tried to put these together as the best as I can. There is not even one or two articles that kind of like say, yes, this is the evidence-based are key ways to diagnose FASD. Unfortunately, we still do not have that. So I did my best to pull all of those together. So what we know is diagnosing FASD is complicated, and that involves, and it should involve, an interdisciplinary team, right? And for those of you who are working in these interdisciplinary teams, do appreciate that. It involves documentation of physical, which we talked about, functional, and neurocognitive deficits in several areas. So the areas that need to be assessed for a good diagnosis is the physical deficits for FASD with sentinel facial features that I mentioned, cognitive academic functioning, screening for learning disabilities, neuropsychological testing, testing for adaptive functioning, and presence of confirmation of the presence for prenatal alcohol exposure. In Brown et al., the article that I mentioned also noted some of the best, practices, and for that, we have to start out with a good screening and referral process. Everything starts there. Screening, process, all pregnant women and postpartum, they need to be screened with appropriate tools and, by, clinicians. And referral for FASD diagnosis or an evaluation needs to be done when there is both evidence of prenatal alcohol exposure as well as suspicion or suspected prenatal alcohol exposure. Okay, and I'll repeat again, the confirmation of prenatal alcohol exposure. We can look at the documents that the mom drank. We could look at clinical observations. We can look at self-reports. We can look at reports by a reliable source, family member. We could look at the medical records that document blood alcohol concentrations. We can look at substance use treatment records of the mom. And we can also look at social, legal, and medical problems that were noted in the medical records during pregnancy due to drinking. Okay, so those are all different ways to confirm prenatal alcohol exposure that a good evaluation needs to kind of like definitely look at. And going back to our audience who asked about the role of a mental health provider who is not specifically a psychologist, all of this part, can also be, conducted, through a therapist or a clinician as well. And then, of course, we need to have the biggest part is the medical evaluation, where we gather social and medical history. Then we have the physical examination, right? And then for the physical examination, we talked about the facial features, the 3 facial features. The palpebral feature length has to be less than 3rd percentile. The philtrum has to be rated 4 or 5 according to that, if you're using the 4-digit code, the University of Washington code, which is more at the severe level. And then the upper lip rated as 4 or 5 again, if we're using the 4-digit code. Okay. And then we already talked about the confirmation of prenatal alcohol exposure. And then for the physical exam, then we're going to be looking at, of course, the height, weight, head circumference, and looking at something below the 10th percentile. And then the third one is neurodevelopmental assessment. And this is the part that we can have different clinicians involved. We can have occupational therapist, physical therapist, we can have speech and language therapist, and then of course the psychologist that is all if we can, conducting this neurodevelopmental assessment. And here we're looking at brain dysfunction, central nervous system abnormalities, and we're looking at a severe impairment in 3 or more domains. And these domains can be motor functioning, cognition, executive functioning, language, academic, memory, attention, adaptive functioning, affect regulation, impulse control, hyperactivity, and social skills. Okay? And when we say severe impairment, we're looking at the global scores or major subdomain scores on a standardized measure, 2 or more standard deviations below the means. Of course, we always have to care for the confidence interval, or what we can look at is a low base rate, less than 3% occurring in the population. So those are some of the criteria that we can use. Just for your information, I put some of the ways to assess prenatal alcohol exposure here, and then some of the specifics that I mentioned for the sentinel facial features that can be utilized. And then all the neurodevelopmental assessments that I mentioned, and then I also listed all the areas that we can assess. So this was again from an article. Again, there are different, thoughts around that too. That can be different configurations. So this is no by means one way or just the ultimate way. So this is just kind of like one way to form the teams if you're all interested in having an interdisciplinary team. For less than 18 months in terms of infants, we need a pediatrician or a physician, child development specialist. Could have a nurse that's also kind of well versed. Sometimes a nurse that's specialized in specifically this area can also replace for the physician as well. Child development specialist who can do the evaluations on adaptive functioning, social emotional functioning, and so forth. And then we could have, if we are needing to look at IQ and neuropsychological piece, which for the younger ages, we don't need it as much. So actually then speech OT, PT, a nurse, physician, and a child development specialist would suffice at the very early levels. When we start preschool, 18 months to 5 years, again, then a psych could replace then the child development specialist because they can do the similar evaluations. And then we need speech OT, PT, and again, physician and pediatrician. The school age, we have a pediatrician or physician with expertise in FASD, and now we're adding the differential diagnosis because this is the time then we start seeing more involvement of co-occurring disorders that the physician has to be well versed in being able to differentiate from different disorders. Okay, OT psychologists can continue to be a part of the team. And then as for adults, then as you can see, we are getting in terms of some of those needs. Hopefully by that time, we have some of the OT, PT related issues, and there are less difficulties around that, around those issues. So we can be fine with a general physician, a psych, and then maybe sometimes speech continues to be there as a part of the team. All right, the next area that I'd like to talk about is comorbidity. So I know that one of our audience was curious about how do we differentiate. Again, because of limited time, I'll talk about what I can within a couple of slides, but hopefully there are some helpful information for you to start to being able to tease out some of these different disorders. But what we should know is that FASD co-occurs with a lot of disorders, specifically neurodevelopmental disorders. As you can see, half is for ADHD. That's a huge number. For ID, 43%. Communication disorders, 67%. So a lot of language disorders and so forth. And around 31% is learning disabilities. So, and as far as for behavioral and externalizing disorders, a lot of comorbidity with ODD and less with conduct. So we're better able to differentiate the two. But you know, a lot with externalizing disorders due to the behavioral dysregulation that we see in FASD. So I picked some of the neurodevelopmental and a couple of like the ones that gets misdiagnosed more frequently. Okay, so the first one is FASD and ADHD. So what are some of the shared aspects? They both have executive functioning problems. They both struggle with focusing and attending, and they both have problems with what we call working memory. Okay, but then what kids with FASD have that does not always happen with pure ADHD is kids with FASD also have gross and fine motor delays. Kids with FASD with ADHD may or may not. Kids with FASD, they have hard time understanding social gestures, social perception issues. We don't see it at that severe level in ADHD, okay? Kids with FASD have more early difficulties with self-regulation and arousal. We see the emergence of those issues in a typical kid with ADHD only more around 4 or 5, whereas with a kid with FASD, as early as 2 years, we can start to see this dysregulation very, very easily. So that could be a marker. And in FASD, we also see issues with visual motor integration, spatial processing, which is not understanding where they stand, the 3D, doing things in their head. Those spatial recognition issues are much more pronounced in FASD compared to ADHD. So the next one is between FASD and ASD. So what do we share? Well, they both display socially inappropriate behaviors at certain points. They both have difficulties with peers. They both have social interaction problems, and they both have problems perceiving the social cues that's coming from other people, right? So those are the commonalities, and just like one of our audience asked, but then how can we differentiate? Well, kids with FASD, they do a much better job of sharing their affect, whereas kids with FASD, they have a lot of problems with affect expression. They can recognize affect, but to express it is a lot more difficult in ASD. Kids with FASD can use nonverbal communication. So kids with ASD, with autism, they have hard time understanding gestures, but also using their hands and facial expressions to convey meaning. Whereas kids with FASD can be very expressive and they can use their gestures much better than ASD. Kids with FASD initiate social interaction and they go towards others. They can be very social, right? They approach peers and they want to be with peers. However, they struggle with when they're interacting. On the other hand, kids with autism, they do not approach, they do not initiate as readily. I'm not saying that they don't at all, because both of the disorders are on a spectrum, right? So kids with ASD, they stay away more, they are more to themselves, they don't initiate as much. Kids with FASD, they show more poor judgment in social situations, and that's the impact of the alcohol on the frontal lobe, where there is more pronounced effects on the frontal lobe, and frontal lobe is the area where we do a lot of judgment and problem solving. Okay, so once kids with ASD, with autism, they approach, the reason why they can't engage in good judgment is they lack the social skills. For FASD, it's more of a brain-based reason. Kids with FASD, they tend to be more overly social, and they are indiscriminately friendly, meaning that individuals, whether they are friends, whether they are acquaintances, they could go into a park and they could easily sit on someone's lap. Again, these are examples and not, generalization in that sense, but if they don't get that safety training, they could be in situations where they could be taken advantage of because of these behaviors. whereas children with autism, they less likely to engage with others because they more prefer to stay away from strangers. So those are some of the ways that we can differentiate. What about with ODD and like oppositional defiant disorder and FASD? Well, we know that both display aggression. They both display noncompliance and disobedience. So that's the common. And we know that a lot of the children, before they're diagnosed with FASD, they get diagnosed with oppositional defiant disorder, or even sometimes conduct, because they put themselves in sometimes in situations where they'll be labeled as not obeying the law and getting in trouble with the law. Okay, so how can we differentiate? Well, children with FASD, they act younger than their age. They're usually described as immature and not up to their age level. Whereas kids with ODD, they are presenting as their age level. Okay, kids with FASD can engage in cruelty, bullying, stealing. It could be more pronounced than what we see in ODD and conduct in that sense. Okay, so this one is really important. Triggers. That's the one way that we can do a good functional assessment, where we can try to understand the reasons why they act up. So this is really important. We can do that really nicely in an interview. We can ask, what are some of the triggers? What makes your child have an outburst? So that's a great question to ask. And what we will find out is that the triggers for the outburst for FASD is oftentimes tied to dysregulation of their system, too much sensory issues, okay, and not understanding the social context or the cues, and not understanding the, if I do this and then this happens, not getting that piece. On the other hand, the triggers for the outburst for ODD are tied to not getting their way, not wanting to comply, and getting a desired object or an activity. So if you take those away, then we really don't see outbursts for ODD. If you give them what they want, they will not necessarily have an outburst. But that's not true for FASD. Even though we can give them what they want, they will still have an outburst. So really inquiring about the trigger for their outbursts would be really helpful to understand whether the disobedience and the noncompliance is a result of more something internal or versus, which is FASD, external, like what we would see in ODD or conduct. And then the last part for the comorbidity is something that we see a lot, which is learning disabilities and FASD. They both display learning problems, and they both display low achievement, as we know. So then what are some of the differential aspects? Some of the differential aspects is that children with FASD, they have much more slow processing than a typical child with just learning disabilities. So when we look at the processing speed scores, we will see that the processing speed scores are around 60s and 70s in FASD, whereas for a typical child with only learning disabilities, we could still see some issues with processing, but more around, low 80s and 90s. Okay. In FASD, we see poor encoding. Encoding is how much we can get new information. So we see more poor encoding and poor memory strategies in FASD as we compare to a learning disability. So when they get the evaluation done for memory, we will see that kids with FASD have much lower memory scores than kids with learning disabilities. And children with FASD require much more trials to learn to remember things, okay? Because of the impact of alcohol on the hippocampus, that area has been compromised, so it takes them longer time to learn than compared to a child with a learning disability. And then the math problems are more pronounced, and therefore math LD is much more common in FASD. And also dysgraphia or writing or graphomotor issues are also more prevalent in children with FASD. Okay, and my last part of the presentation for today is about talking about screening and why screening and the referral process is really important. So before we transition there, I'll also stop to get questions regarding the part that I just talked about.
Questions that I have, looks like 4. The first one is from Ashley Sabilla. She said, I heard in a previous webinar on FASD from a different organization that FASD is commonly not diagnosed till after age 3. That would affect early intervention eligibility requirements since it is only till age 3.
That's a wonderful question. Thank you so much for asking that and highlighting that. And that's something that I missed to talk about, the age of diagnosis. So thank you for that question. First of all, what research shows is that the age of diagnosis for FASD is 9.5. So what that means is we are currently able to diagnose with our tools and referral process and so forth. We are waiting till 9.5 years old to diagnose FASD, which is pretty, for a neurodevelopmental disorder, which is really late. For autism, do you all know when it gets diagnosed? It's 5 years old. So we are much behind. That's to begin with first. But then back to your question, yes, it usually is not very easy to diagnose before age 3. And then the reason is this. We are looking at a lot of the neuropsychological markers, such as executive functioning skills, memory, and learning. At the very early ages, we know that those skills do not develop as much until they hit the school age. And our tests, we do still have great tests, but before age 3, we really cannot measure successfully what an executive functioning is. Okay, I've done evaluations as early as 4, and I did diagnose by 4, but not really before 3. So our best bet is, and I'll talk about it in the referral section, is if we know there is alcohol exposure, okay? And if we can determine the presence of developmental delays, such as low IQ, OT, PT, and so forth, we document all of those in the report, and we document the presence of alcohol exposure because we know that that's key to the diagnosis later on when they get an evaluation. We provide all the early intervention services maybe under another diagnosis like ID or early like developmental delay under DSM-5, because anyone under age 5, if they have any developmental delay, they can be diagnosed with that, right? So we can provide all those, get things rolling, and then when the time comes that we can actually more reliably measure, then we can go ahead and do that. Again, I don't know from the audience, especially Sister Suzette had a lot more experience than I did over the years for some of the different ages that were diagnosed. But personally, the earliest that I've diagnosed was 4. I think at the Minnesota clinic, we did diagnose one at age 3. But before that, even testing could be, extremely difficult for that age range.
Okay, this next question is, I think you answered it. Christy Hannon is asking, what is the earliest age recommended for diagnosis of FASD conditions?
Yes, I mean, if we can hopefully screen by around that, age of 3, and then just kind of like, or get the things up and rolling, due to the developmental delays, okay? After that, I think if we can start the interventions, I think that's going to be really helpful. And then I would just recommend for all of you working as maybe early intervention specialists and you're learning about FASD, you can always put in your reports or records that there is suspicion, there is confirmation of alcohol exposure, and a lot of red flags around FASD that you have learned about and you've heard about. If you put it in your report, that would be just gold type of information, because as later, for those of us who are evaluating, we look profusely at those reports from all of you who have worked with them in the early intervention, early childhood stages. And if we see any of this, we just latch on to that information, and that will make the evaluation so much easier.
Okay, the next 2 questions are from Sister Suzette, and she's asking, are you diagnosing adults at your clinic?
So currently this year, for those of you who know me, we had a clinic at downtown Dayton. It was called Ellis Human Development Institute. There, I was working 0 to 18. So a lot of the clients that I work with was with 0 to 18, age range. And this year, because of the COVID, they closed our clinic. So this year I have not been able to do any evaluations. Next year, we'll have an internal clinic at Wright State University, and I'll be working with another child and adult psychologist who's also well versed in the area of FASD, that I'll still do the child evaluations, working with the genetics of Dayton Children's, and forging our relationships more for the screening part and some other referral processes. And then she'll be able to do some of the adult hopefully evaluations there as well. But I have not done adult ones so far. I always focused on child, being a child psychologist.
So she's wondering if you diagnose adults, how can she refer you when you are open again your clinic is open again?
Yes, definitely. And then I will send all that information through our committee, and then just being part of the committee, of course, you'll have that access to information, because I know we're always updating referral sources for annually and so forth. So I'll make sure to add the our intake website and so forth. So definitely, thank you.
And this is the last question from Sister Suzette. She says, we typically diagnose ages 5 through 17.
Mm-hmm.
I encourage parents who have children younger than 5 to join our parent support groups and use our Triumph Today series on our website, which is the Double Arc website.
Yes, excellent. Yes, thank you, Sister Suzette, for that information. Because with that, they will start getting, as I said, that's the best, method right now. They will be flagged, right, and identified kind of without maybe the diagnosis, but they will start the interventions, which is, through the Triumph program and so forth. They will get the psychoeducation, which is like golden. And then when the time is right that we're able to provide, as I said, that school age, starting that kindergarten and so forth, then, we can go ahead and provide the diagnosis in a more reliable manner. So that's wonderful.
And that's all for the questions right now.
All right. Thank you so much, Karen. And thanks for the wonderful questions, everyone. All right. So the last part, I'll talk about the screening and the referral process. We already established why early diagnosis is important. Early and accurate diagnosis is the key to help them reach their maximum potential. As that, Sister Suzette has mentioned, we can help the families and the schools get a good understanding of what the child may be experiencing. Psychoeducation is the key here, and support. And we can give the family and the schools direction on how to help the child receive these targeted interventions. And it also is very important for a better prognosis. And it reduces the likelihood of adverse outcomes. It reduces the likelihood of secondary disabilities, such as depression, dropout, substance use, and so forth. So risk of the secondary disabilities increases if the diagnosis is made after 6, because after that, if they start to get the misdiagnosis, they start going on to a different route. And that route is definitely not helpful. So as we know from Dr. Chasnov's latest, the 2015 research, that there is almost like an around 80% rate of missed diagnosis, because FASD, as I mentioned, shares the same behavioral patterns with other neurodevelopmental disorders. So misdiagnosis means incorrectly diagnosing FASD for another disorder. So saying it's ADHD, whereas it's FASD. But we also know that they co-occur, they are comorbid with one another. So we can diagnose them at the same time, okay? The misdiagnosis meaning that failing to diagnose FASD when it's actually there, but we miss it, okay? So those are the two big concepts that happen when we're not engaging in an appropriate screening and referral process, which leads to, which I've been talking about all today, secondary disabilities. Unaddressed symptoms of FASD lead to development of secondary disabilities such as depression, anxiety, dropouts, getting into trouble with love, 70% of our kids, inappropriate sexual behaviors for which they can also get into trouble for, and more drug and alcohol use difficulties. So when should we refer? We should refer when we have evidence that the mother consumed alcohol during pregnancy, or, as I said, we suspect that the mother consumed alcohol during pregnancy, because sometimes, as much as we can try, we cannot have all of that evidence in our records, but we have that suspicion based on our conversations, but they're not sharing it with us. We can still go ahead and refer. And of course, if the child possesses the facial features characteristics of FASD that has been either documented by a report, by genetics, by a prior doctor, or we can suspect it again as well. And if the child displays the behavioral and neurocognitive characteristics of FASD, which I have outlined more specifically in my first training, where I talked about the red flags of FASD. So in terms of the screening process, as we know, screening reduces secondary disabilities, and it decreases the misdiagnosis and so forth. But what we also know is that, as I mentioned, the average age of diagnosis is 9.5. That's very, very late. So we also know that more than 66% of children with FASD do not receive early intervention. For all of those working in the early intervention area, follow afterwards. Okay, so we need more screening, which could lead to referrals, which can have more positive outcomes and improve our approach and improve the feasibility of attaining the appropriate interventions. So then what is the purpose of screening? Is to identify the individuals who are at risk for FASD. It's not to diagnose, so that's not a task of diagnosis, but it's to ensure timely and appropriate interventions for our individuals who might be at risk or who already have it, but we don't know it yet because they're so young. We need more screeners, and because of this, I, along with my dissertation student, we developed a screener based on looking at some of the limitations, I would say, of some of the screeners that are out there in the literature. Okay, a lot of the screeners that were out there required long-term knowledge of the child, like you had to know the child long. But what we know is that 80% of the children around with FASD do not live with their birth parents. They are with their adoptive parents, and once they have them, they could immediately bring them for an evaluation, and they might not know the child that long. Or for a positive screen, they want an evidence of facial features, but it only captures what we talked today, FAS, and not the other diagnosis under FASD, or confirmation of prenatal alcohol exposure. So if we cannot confirm prenatal alcohol exposure, but we suspect it, but if it still has a positive screen, we can go ahead and get at least early intervention services started. We may not maybe give the diagnosis, but giving the early intervention services, OT, PT, speech, that's going to get them ahead. So therefore, we really shouldn't be tied up with the confirmation of prenatal alcohol exposure for the screener. I'm not saying for a diagnosis, but for the screener to be utilized. Of course, it always has to be cost effective, easy to administer, and not require extensive training, because as we know, medical providers, there's not a lot of time. There's no time to learn different things, and it should be easy because they only have 10-15 minutes, right? And it should be used in a variety of settings, not just medical, but mental health, all of us, right? And those of us in the foster care settings, because as I said, 70 to 80% of the children will come to you because they'll be in the foster care system. We also need to identify children under the age of 5, again, just like Sister Suzette mentioned. So get them together with support groups, psychoeducation programs, even if we can't yet do the diagnosis for the ones that are under 5, but we need to catch them early on to tie them up with early intervention. So those are some of the why we need a screener. So we mentioned why we need it for these different types of settings. Who could be the user qualifications? We wanted to keep this very broad because we understand there are a lot of professionals who might have an encounter with FAS, individuals with FASD. So it can be any psychologist, any physician, nurse practitioners, physician's assistants, licensed clinical counselors, social workers. So they can be used with all, as well as any foster care or adoption counselors can also utilize this screener. I'm hearing some feedback. I'm hearing some feedback. Somebody's name is not muted.
Huh?
All the participants are moving. What's going on? This is
I'll
really
just
weird.
pause for a second until we can maybe help to mute. Okay, I think it's taken care of. Thank you.
Wait a minute, I see one person that's not muted.
Okay, can we all mute? Not to have feedback?
That's okay. I got it muted now. Thank you.
Okay, thank you. So for our screener, we developed two versions of the screener. One is the early childhood version, 2 to 5, and then the school age adolescent. It's a bigger age range, but to capture the 6 to 18 years of age. And the reason for the two versions is FASD, as we know, and as I talked about in my first training, it presents differently across the course of it. It presents differently in infants, toddlers, preschoolers, school age, adolescents, and in adults. And I've talked more extensively in my first training about that. So what we did is we derived the questions from the literature as to what research is pointing us to. We looked at the past and current screeners, we reviewed them for their strengths and their limitations, examined each of the questions as to why they were chosen. We reviewed their reliability, validity, how specific and how sensitive each of that information was. And we looked through all the online databases and so forth to look at all the different screeners. We tried to fill in the gaps that the previous screener attempts did not necessarily cover and tried to add those aspects. So as far as for the results that I wanted to share with you today, 5 domains were chosen, which I will explain. And then the questions for each of the domains were supported by the literature review and were picked as the best representation of FASD characteristics. Okay, and both screeners were determined to be at an 8th grade reading level. So in the literature, in terms of the central nervous system domains that I've been talking about, we have neurocognitive functioning, right? Neurocognitive functioning is everything regarding the impact of alcohol on the brain. So therefore, we know that for FASD, the areas that get impacted are memory, attention, language, motor functioning, executive functioning, intellectual, achievement, and visual spatial. So we made sure that we asked some questions around each of those domains to see what kind of neurocognitive impairment is there that we can capture, at least at the beginning. We can't say that for sure, but at least we can capture as a to screen for. Then we looked at adaptive functioning because we know that in FASD, adaptive functioning is impaired and it's below average. Then we looked at behavioral functioning because it's an area that gets impacted. We see a lot of behavioral dysregulation in FASD, so we wanted to capture that. We see a lot of social problems that I just talked about when I talked about comorbidity, right? And then we also see a lot of mood swings, mood changes, emotional dysregulation. That is also a marker for FASD. So what we did is we delved into the literature as to what are the aspects of each of these areas that come to the surface that we can say we see a lot of these issues in a lot of our children or adolescents with FASD. Okay, and then I put down some of these facts. I'm not going to go over each separately, but I want you to have that information. But 70% of children with FASD have attention problems. Therefore, if we screen for attention, we sure will be catching a lot of children. And a lot of children with FASD have memory problems, especially working memory, verbal learning. So if we go ahead and ask about memory, we will capture a lot of those children. Okay. A lot of the children with FASD start out life with a lot of developmental delays. So if we ask about those, we will pick those children. A lot of them have motor functioning issues, right? So if we ask about it, we can, pick those as well. So those are just some examples. So these are some examples of the questions from the school age versus the early childhood version. Okay. So some of these questions are, does your child have trouble remembering things that they have learned? So here we're capturing memory issues. Does your child have difficulties with concentration and attention? So kind of like very basic, simple. Have learning difficulties in school. Math. Remember we talked about math, comprehension. They struggle with comprehension. Does your child have difficulty understanding like cause and effect relationship or consequences to their actions, right? And then the early childhood ones are talking about more developmental delays, okay? Difficulties with fine and gross motor skills, again, with comprehension skills. So those are some of the ways that we try to capture early problems when they are really young. For the adaptive functioning, we found that a lot of the kids have feeding and suckling problems, sleep problems, toileting, bathing. Those are all challenges. Big time, telling time, understanding money. Those are big struggle for kids with FASD. So we haven't really found mentioning of those in other screeners. So we wanted to make sure that because the literature really talks about it, that we should add that in our screener, hoping that we can capture more children who struggle with those. This one, requiring constant supervision, needing for frequent reminders, tasks broken down, okay? Having poor judgment, difficulty learning from experience. So these are all things that we have also found that children with FASD struggle specifically more than other children who have other neurodevelopmental disorders. So these are some of the questions that we came up with. Poor sleeping patterns, requiring constant supervision, difficulty telling time, handling money, right? So these hopefully will capture all of the adaptive functioning difficulties. Again, probably not all because it's a spectrum, but at least some of them. For the behavioral functioning area, we know that kids with FASD struggle with intense temper tantrums, okay, mood swings, anger outbursts, and then sometimes engaging in inappropriate sexual behaviors. They have disinhibition, sometimes confabulation and lying, and being disobedient and so forth. So to capture that, we asked about inappropriate sexual behaviors, lie, but we put it as like making things up. We didn't want to write confabulation, it's a big word, but lying or cheating, trouble with authority, active impulsively, anger outbursts. So they would all hopefully capture all of the behavioral difficulties. For the emotional one, difficulties with being soothed. For those of you who have kids with FASD or working with this population, you all would appreciate that some of those difficulties with self-soothing, right? And then that lead to issues with attachment. Sensory difficulties, right? Regulating those sensory difficulties and some comorbid issues. So we said things like trouble bonding as they were when they were infant, trouble soothing down, trouble with certain textures, temperatures, noises, right? Easily overreact, sensitive, overly sensitive. So maybe this will capture some of the kids on this autism spectrum too, but all in all, when it's all put together, this is more likelihood to capture some of those sensory difficulties. And then the social area, we have a lot of problems with understanding social cues, boundaries, lack of strangers, acting younger than their age, right? Difficulty making friends. So these are all the things that we tried to capture, like socially naive. This was some of the verbiage that was used in other screeners as well. Overly friendly with strangers, acting more socially immature, difficulties with judgment. Okay, so these are all the things that we thought would capture the social issues. So, and then we also had some supplemental questions. So we know that a lot of the kids don't live with their biological parents. So a history of exposure and history of being in the foster care system is a big marker that would actually help us capture and catch these children who are in the system. Okay, so we also know that when there is no facial features, they're more likely to be misdiagnosed or have a misdiagnosis. So we did not make the facial features as just the focus of the positive screen. So in this screener, you can have a positive screen even if you don't have the facial features, because if you have it, that's great. Then that means you have FAS. That's wonderful. But then what if you don't have FAS? Then are we just like saying, no, I'm sorry, you didn't have a positive screen, so we cannot move forward? Okay, so we thought that wasn't really fair for all the kids who were on that RAND, diagnostic section, and therefore we put the facial features and the growth issues as supplemental, but not necessary for the RAND, that to be able to capture that piece. But if they are there, of course, we will move on the spectrum to partial or to FAS. So the supplemental questions are, is the child in foster care or have been adopted? Well, that will help to capture a lot of kids. And is there confirmation and use of during pregnancy, denied, suspected, confirmed, or unknown? And then this section only done by physicians, nurse practitioners, physician's assistants, whoever is qualified to do that. So nothing like counselors, psychologists, and so forth. So not for them. The height and weight, head circumference, and the facial features, the three ones in the literature that I already talked about in detail today. So in terms of the administration, this can be administered in a medical setting, mental health, or a foster care setting. Professional can ask each question, circle yes or no, or the families can also, just like the MChat for autism, they can be given this and they can actually answer these questions without needing an interview. It's a response of a yes or no, so that's pretty easy. But I'll get your attention. How mild or severe the deficits are, the screener is not asking about severity. So it still requires the comprehensive evaluation to determine where on the spectrum the child might be, because the screeners are not helping with, they're not diagnostic, right? And they do not determine severity. So I just wanted to specify and indicate that. And then there are lines that are indicated if the caregiver or the parent, whoever is filling this out, wants to give like more information, then that's possible too. If the caregiver has hard time answering the questions because they just adopted the child or they just started fostering the child and it's not been enough time, it can be repeated at the next visit. So it doesn't mean that it ends there because they just don't get to know the child. Okay. And then the last three questions I mentioned, the physicians, nurse practitioners, physician assistants can complete them. But if it's not possible, they don't have time and so forth, it's okay that they might not do that, because in the actual evaluation, when we refer them out, they will already get that full-on medical evaluation anyways. But it should not really stop us from screening our children. So how we score, we add the number of yeses and nos. If less than 25% questions endorse yes, then we're good. No further eval is necessary. If 25 to 15 of the answers are endorsed yes, then they should, it's like on the cusp, so they should be screened again. So we put a note in the records that there are some symptoms, but not at the full level. And if more than 50% of the questions are endorsed yes, then it's a positive screen and the child should be referred for further evaluation. And then even if the number of yes answers are between 25 to 50%, but one or more of the supplemental questions are positive. Remember, that is, yes, they've been exposed, yes, they have facial features, yes, there is growth retardation. Again, we refer for further eval. So for us, this was a win-win. If you have the medical part, you refer. But if you don't have it, but if you have all the neurocognitive and the central nervous system pieces positive, you still refer. We are not tied in with having all of that in place to start the referral process. Okay, and a positive screen for height, weight, head circumference, or any measurements face below the 10th percentile, if that's done, that can also lead to a positive screen, right? Because then these will capture the FAS and the partial FAS, and everything else will capture, if these are not there, the RAND part. So how do we decide based on these recommendations, based on the screener? So what we can say is recommend that a child refer to an FASD clinic, just like the double R, Renewed Minds, and then for a diagnostic evaluation, which could include a developmental pediatrician, a psych, neuropsychologist, nurse practitioner, geneticist, neurologist. Again, the makeup of the team is based on what that clinic decides to put together, based on which diagnostic platform that they are following. And then if needed, the child can be referred to an OT speech to address the fine motor skills and speech problems. So get the early intervention services started, right? So that also helps with that part and not waiting for the diagnosis, okay? And then primary care offices, mental health clinics, they could have a list of recommended sites for the families. And a lot of the sites can also be found on the NoFast website and on our committee's website as well. So what about those cases where we don't have a positive screen? What do we do with them? If no referral is needed at this point, but the child is still showing some behavioral concerns, the professional filling out the screener can identify and document them, needing that the child still needs developmental services. Okay, so we don't just leave it there, but they should continue to monitor the child and consider to screen again in the future to see if they need a referral for a comprehensive evaluation. Okay, so it's really to set the stage and then to get the ball rolling. So what are the clinical implications and utility? Again, we want to make sure that the early intervention services get started easily. We want to make sure that it helps to reduce stigma. Remember, we talked about stigma. The more we screen, the more everyone knows about it. The more people know about it, like autism, it starts to decrease that stigma as well. It improves education, training, and research opportunities. And by providing the early interventions, it can improve, of course, overall cost and economic spending there as well. So all in all, for a good referral process, we need this interdisciplinary collaboration. Physicians, nurses, psych, social workers, OTs, PTs, speech, law enforcement, media, teachers, school. We all need to work together. And that's kind of like my model and my motto for that interdisciplinary collaboration, where we have to work at that prevention level, at that screening level. When we screen, we have a positive screen, we refer. Then we provide the evaluation, the diagnosis, okay? Then we refer out for treatment to different people. And then we come back and follow up and reevaluate. And we work in conjunction with different members of this interdisciplinary team. So how can we all help? What can we all do from our part? Parents are well equipped. If you are a social worker at a foster care agency, you can well equip them as to what they should expect when they will adopt children with FASD. Like in Dr. and Sister Suzette's clinic, they provide those psychoeducations. There are a lot of support groups they do, and many other support groups that are out there. I know Aubrey also has a lot of support groups for the parents. They can provide respite care as well. We can do our part to understand the red flags, which in our prior training we talked in length about those. We could know when to refer. So hopefully this presentation and this training provided some information and knowledge about when and under what conditions would be helpful to refer. Or you could be you could be a social worker, clinician, mental health provider, a doctor, nurse, psychologist within this multidisciplinary team to do your part in providing this diagnosis, which, as you have seen, is a big undertaking. Or you could be in the form of doing advocacy. I know, again, Aubrey, I always give a pick on her, but she does a lot of that advocacy for the needs of their children and their families, both as a parent, but also even if you're not a parent and have the lived experience, you can also engage in some of those trainings to to be a peer support for those families. And then the final piece that I'd like to talk about is, what are our current roadblocks? What is it that we're struggling in this area of FASD, both area of screening, diagnosis, referral, and further on for treatment? We have a lack of understanding and knowledge for FASD, and this is the part that I hope that I'm doing my part to provide trainings, and I know a lot of us are in the committee and in the state of Ohio through different works, through different trainings. We're providing more and more information to spread the information, the knowledge around FASD. We have lack of established referral processes. Again, I hope that I was able to showcase a little bit of this, but again, we need more established. What is the gold standard for referral process? We still need to perfect that piece. We have lack of consistent diagnostic systems to diagnose FASD. We have already talked about that in detail today. Lack of consistent screener use. It's very hard for different organizations to buy in the need to screen for FASD. They're all good to screen for ADHD, for autism and other disorders, but they're not there yet to have that buy-in as to why do we need to screen for FASD. So we need to work on that piece. We have a lack of adequate clinicians to engage in any FASD work, right? For just, if I could see all of your names, I would count, just because the questions came from some of those that I know already. I know you're doing wonderful work already, but you are just one, that we can count in the whole state of Ohio. Lack of adequate number of FASD clinics and developmental clinics who conduct FASD diagnostic evaluations. That is of a bigger concern there as well. As you know, you all would, appreciate, and I know Double Arc and Sister Suzette would appreciate, because she's done that for years, how hard it is to sustain a clinic like that, just because of the number of referrals, how comprehensive this evaluation is, and funding and so forth. That's definitely an issue. And then lack of adequate number of providers to provide treatment services. So we don't stop at the diagnostic level. So then what comes, which is my next training in April, is regarding all the different treatment modalities that are out there, and who does implement them. What can we do from our part as counselors and therapists? How can we integrate some of those evidence-based treatments into our day-to-day practice? And then finally, lack of interdisciplinary work and understanding to refer, diagnose, and treat. We also kind of tend to work in silos, which is not good. As I mentioned, I would have loved to be a part of an interdisciplinary team. I enjoyed my work when I did it at University of Minnesota Medical School, and I was part of the team. I did my part, others did their part. We put all of that information together. That's so much more fun to do than trying to do one piece and then trying to almost copy and paste everything together. So we need more and more interdisciplinary work to make this all happen, so that we can serve our children and adolescents and then adults who present with FASD, and their families who are working so diligently to get through this process of getting a diagnostic evaluation, getting them screened, getting them diagnosed, referred, and then finally providing treatment. All right, and I put some, resources and so forth. Thank you so very much for listening today. I will now get the last pieces for the questions and do my best to address those questions as well. But if you have any questions, and if you don't have time to stay a little bit for listening to those questions, please feel free to send an email to my email address. I'd be happy to share resources, articles, anything about the diagnostic systems, and I'd be happy to consult as well. Again, thank you so much for listening, and hope it was a helpful presentation today.
We have a couple of questions. This one's from Aubrey Page. She says, is the height, weight, and head circumference below 10th percentile at any point in their life, or when screener is done?
At any time in their life. all of those growth-related ones are going to be, prenatal, postnatal, and at any time, not at the time of screening. Because by the time they're older, and if you only got them at age like 10, they might have compensated and they might not display it at that time. If you have it in their records, then that also counts.
Sister Suzette, are you able to share your screening tool?
So for that, at this time, it's still at this stage of being, finalized and approved. And once it's out there to be, ready to be utilized, yes, of course, definitely. And that's the purpose, for it to be able to be utilized. But with the caveat that it does not have the piloting and so forth yet. So I would still make sure that everyone uses it with caution, because we still need to work on the piloting process, where I'll have to document that it has good reliability and validity. So this is just the very initial stage, hoping that that's where we're going to go to, that we can kind of like publish and so forth. But this is at the very beginning and crude stages. So I want to put that disclaimer there as well. Definitely.
And that looks like all the questions, Dr. Ergen. The
That
rest
was
of
it? Okay.
comments on your excellent presentation. Thank you,
Okay.
Dr. for another good presentation. We will have our next one. I think it's April the 23rd. And we look forward to working with you.
Thank you, everyone. Thanks for listening.